Welcome to today's webinar. My name is Tammy Lytle, Registration Manager at IAS-USA. Today's webinar will be going over geriatric assessment for people with HIV. I'd like to welcome our presenter, Dr. Meredith Greene, Assistant Professor of Medicine in Geriatrics at the University of California, San Francisco. Welcome, Dr. Greene.
Great. Thank you so much, Terry, for that introduction. You can see what our talk is today, and I'm just going to be starting by going through some logistics. So the IAS-USA has approved this activity for 1.25 AMA CME credits. This course has also been approved for 1.25 MOC points, as well as 1.25 nursing hours, pharmacy hours, and pharmacotherapy credits. As you can see, instructions for claiming credit will be emailed to you. Support for this webinar has been provided by the following contributors shown here on this slide. And just the logistics for today, there will be poll questions for our pre and post test. We're going to do a practice one here in a minute. A separate window will pop up. You'll choose your response, and then after the poll closes, the responses will be displayed. For questions, submit those via the Q&A box at the bottom of your Zoom window. As noted, you need to include your first and last name for your questions to be answered, and we're going to try to get to as many questions as we can. We already have great questions that came in with registration, but we apologize if we can't get through all of the questions. With that, we're going to do the practice poll. So you're going to please rate your level of experience in the medical management of HIV infection from 1 is novice to 5 expert. Okay, and here's the result of our poll. So the most popular response was right in the middle. So we have a good range of people on the call today. So this is great. So with that, we're going to begin. That covers the logistics. We're going to begin now with our content today, which is about geriatric assessment for people with HIV. My disclosures are listed here, as well as disclosures of the slide reviewers. So the goal for today is really at the end of this next hour and 15 minutes is to be able to list or describe common geriatric conditions in people with HIV, describe some assessment tools that can be used to identify and treat these conditions. And then throughout, we're going to talk about practical approaches to how you can integrate geriatric assessment into clinical practice, especially busy outpatient settings. A few things I wanted to touch on. One, these objectives, I wanted to discuss how they relate to the 2020 updates to the IAS-USA guidelines, which now includes the section on HIV and aging. So we are today going to talk about multimorbidity and polypharmacy and how to address polypharmacy. And then we are going to talk about geriatric conditions, specifically frailty, falls, and functional impairment, and talk about approaches to doing this. A couple caveats. I always get carried away and could talk a long time on this. There were lots of questions about neurocognitive concerns, and that is in the IAS guidelines around cognitive function and mental health. Because of time, I'm not going to cover that topic today. If we have time in the Q&A, I can answer some of the questions that came in. Dr. Valcour has done IAS-USA webinars dedicated to this topic, and this is being reconsidered as another topic given the number of questions that came in. And there's also an upcoming webinar around mental health and substance use. So we're going to go to our first pretest question. I will read the question and the responses are in the poll. So this is a 63-year-old cisgender male who has HIV, hypertension, COPD, diabetes, arthritis, chronic kidney disease. He admits that he's struggling to take all of his medications. For simplicity's sake, I don't list all the medications here, but he's taking 7 in addition to his antiretroviral medications. And so what of the following choices is the best step to address polypharmacy? And you can see the choices. Is it to switch his ART regimen for another with fewer drug-drug interactions? He's on dolutegravir, abacavir, and 3-TC. Or is it to identify potentially inappropriate medications, provide counseling on ART adherence, or you feel given the number of comorbidities he has, his medications cannot be reduced? Okay, and yes, so 81% said identify potentially inappropriate medications, which is the best answer. We will talk about addressing drug-drug interactions, and all of these things are really important to counseling on adherence and ART, but we'll talk more about potentially inappropriate medications specifically. Second question, a 75-year-old cisgender female who has HIV, hypertension, diabetes, and neuropathy is asked routine fall screening questions when she comes in for her primary care appointment using the CDC STEADI tool. She denies having any falls. She denies feeling unsteady, but she is worried about falling. What is the next best step? Is it 1, nothing else is needed because she did not fall and you can re-screen her next year? Is it that you should actually go ahead and evaluate her gait? Or 3, provide education on fall prevention? And again, what's the next best step? Okay, and the results of our fall. So no one said nothing else is needed. About 2/3 evaluate her gait, and about 1/3 said provide education on fall prevention. And great, we're going to talk more about this in the talk. So just so everyone's on the same page, why are we talking about geriatric assessment? And these are 2018 numbers from the CDC showing that in 2018, over half of all the people living with HIV in the United States were age 50 or older. Before I go further, often asked, why do we use age 50? And this is because there's data suggesting that comorbid and geriatric conditions occur at relatively younger ages amongst people living with HIV. A lot of this may be driven by chronic inflammation, changes in the immune system and immunosenescence. And I think one of the active areas of research is trying to understand how the changes that occur with HIV are similar or different from changes that occur with aging in the immune system. And I think what we can ultimately learn from HIV will likely inform a lot of our biological theories of aging, including inflammaging. Today, though, I'm not going to be talking about mechanisms. This is going to be much more clinically focused talk. And I would point out that whether we're saying age 50 or age 65, which is often used to define geriatrics, both of these are really arbitrary cut points. And the reality is, it's not that magically one day you wake up and suddenly you're 50 or 65 and you're old. Aging is really a continuum, and everyone ages differently. And so unlike in pediatrics, where children reach certain milestones and their expectations for development, how we age is very different. And there's more heterogeneity amongst older adults than any other age group. It is important to recognize what is a normal part of aging versus what is not normal. And I first point out that aging is not a disease, despite the way our society treats aging, despite the fact that there are people claiming that they will cure aging. It's not a disease to necessarily be cured. It is a physiologic process, and some of the changes that occur with normal aging are decline in GFR, a decrease in lean body mass, and an increase in fat tissue. Both of these things I highlight as they will affect pharmacokinetics and how our body processes drugs as we age. For example, lipophilic drugs are going to hang around longer because there's increased fatty tissue. Decline in bone density, decreased cardiac output, partially driven by increase in myocardium and arterial stiffness, and changes within the lens and changes within the inner ear that affect high frequency sounds, which is why some people start to need reading glasses and some people need hearing aids as they age. And just to point out that it's not just distinguishing what is normal versus not normal with aging, but also we really need to approach older adults differently. And this is because with age, diseases often present atypically. They're not the classic signs and symptoms. It can be a change in mental status, or delirium may be the presenting concern for infection. And we certainly saw this with COVID-19. And in general, aging is a state of lower reserve. And so small insults can cause a significant problem. But the converse is also true, that a simple intervention like stopping a medication might actually help to alleviate someone's confusion. And just to point out that with age, the idea of one unifying diagnosis often does not apply. And we're going to talk more about geriatric syndromes, which by definition are multifactorial in nature. So when I talk about geriatric assessment, often we think about comprehensive geriatric assessment. So what does that mean? And the classic definition is this multidisciplinary evaluation where problems of an older person are uncovered, services assessed, and a care plan developed. Often it is done by a team of people, as shown here. And really, there are different models, but the key steps are, one, that you figure out who you're going to screen and how you're going to target. And then you're going to conduct the assessments, develop recommendations, but also implement the recommendations. So in a sense, the term assessment is a misnomer, because it's not just assessment, it's also developing a plan and following through on that plan. And we'll talk about how, if you don't have this team, how we can do this throughout the talk. Another way to think of some of the core components of comprehensive geriatric assessment is the framing of the 5 M's of geriatrics. And these include what matters most, so goal-directed care. And one of the common themes you're going to hear throughout today is an individualized approach to care, because I mentioned everyone ages differently. Mind, which includes cognition and mental health, mobility, which would also include falls and frailty and function, medications, and multi-complexity, the 5th M. And I included here a reference because my colleagues, Dr. Karras and Dr. Erlandson, have written a review article about considering the 6th M in HIV, given the relatively younger age for people, and adding modifiable. But I think what's really relevant to HIV and aging is this idea of multi-complexity. And I actually think that HIV is an example of a multimorbidity. This figure here is one example of study that shows that people with HIV have higher prevalence of multimorbidity compared to their HIV negative counterparts. This is from the HIV age cohort. You can see the HIV positive group had a higher prevalence of these dark bars indicating 3 or more chronic conditions. And it's not just multimorbidity, it's also geriatric syndromes, which we'll talk about today, and then also really complex biopsychosocial situations. And because of time, we're not going to be able to talk about a lot of the social context of care, which is critical and is a part of geriatric assessment. This may be unique social and economic issues, especially for long-term survivors, and also the overlap of stigma and mental health. But I emphasize multimorbidity because it really requires a different approach. You cannot approach multimorbidity as just the sum of all the things on a person's problem list in their medical record. And why is that? So if you try to do every individual disease guideline, this is what happens. This is a classic article in Geriatrics that shows for a 70-year-old woman who has osteoporosis, diabetes, arthritis, hypertension, what her day would look like if you tried to follow each guideline for each of those conditions. Also important to recognize, if you started to add ART in here, that would even add further to the complexity. And in general, the guidelines were not based on, one, older adults, because oftentimes older adults are excluded from clinical trials. Two, the guidelines are usually focused on people who just have COPD, for example, not someone who has COPD, arthritis, diabetes, etc. So it can be really hard to interpret the data for someone with multimorbidity. And I'm not going to go in depth on these 5 domains, but just to point out that the American Geriatric Society does have references available for how you can approach patients with multimorbidity. And the key here, again, is that this is going to be an individualized approach. And it includes patient preferences, the evidence, which I alluded to, which is sometimes a data-free zone, frankly, treatment complexity and feasibility, and optimizing therapies and care plan. And I just wanted to touch briefly on considering prognosis and what that might mean. So many interventions that we do have immediate risks and delayed benefits. For example, colon cancer screening, you need a life expectancy of at least 7 to 8 years to see the benefit of being screened for colon cancer. But if you send someone for a colonoscopy, there are immediate risks in that procedure. And you're potentially, if they have less than that life expectancy, exposing them to the risks of the procedure with little chance of benefit of detecting an early cancer that would actually affect their overall life expectancy. Conversely, things like a knee replacement, which might only be months of recovery, might still be useful for someone and improve someone's quality of life, even if their life expectancy is more limited. So again, an individualized approach, and we'll talk about how some of the other assessments can help estimate someone's overall prognosis. But the main reason I also wanted to talk about multimorbidity is really to talk about polypharmacy. Again, one of those recommendations in the IAS guidelines that came out last year. So like multimorbidity, unsurprisingly, polypharmacy, which travels with multimorbidity, is higher in people living with HIV, especially people over age 50 compared to their younger counterparts. Polypharmacy is important because it may affect adherence to ART and non-ART meds, of course, increases the risk of drug interactions, which are already very common with antiretroviral medications. And there have now been studies showing that polypharmacy in people with HIV is associated with falls and even symptom reporting. And polypharmacy is often defined as being on more than 5 medications. So I wanted to introduce a case, and we're going to use this case throughout the rest of the talk. So this is a 68-year-old male who identifies as an HIV long-term survivor. You can see a CD4 count within the 600s. He had had an undetectable viral load for many years. You can see he had multiple other problems, including hypertension, hyperlipidemia, neuropathy, diabetes. He has an enlarged prostate and some renal insufficiency. You can see all of his medications and their doses are listed here. Comes in for a routine visit, doesn't have specific concerns, but does mention when you're talking about how he's doing with his ART adherence, he starts bringing up how many pills he's taking and that this is getting overwhelming. So how could you approach polypharmacy? So there are 6 steps here that we're going to go through in the case, but just to point out that the 2020 European AIDS Clinical Society guidelines also have this algorithm that is very similar on how you can approach polypharmacy. And as many of you answered correctly in our pretest question, one of the first steps is actually to look for potentially inappropriate medications. And what are potentially inappropriate medications? So if you're not familiar, these are things like medications on the American Geriatric Society Beers criteria list or the European Start-Stop criteria, which are lists of medications to avoid in older adults because often the risks of the medication or the side effects can outweigh the benefits. There are also lists of drug-disease interactions, so specific medications to avoid based on an underlying comorbidity. Examples include things like diphenhydramine or early antihistamines because of the anticholinergic side effects. And you can see alternatives would be potentially a newer generation antihistamine or benzodiazepines, because again, it's a lipophilic drug, it's going to hang around longer, but there are also increased risk of sedation beyond what would be expected from pharmacokinetics. So these are examples. These, again, this table is from those 2020 guidelines. And I reference PIMS or potentially inappropriate medications because simple interventions have been shown to be effective at reducing these. So this is the Empower trial, which was a cluster randomized controlled trial of pharmacies in Quebec. The randomization was at the level of the pharmacy. Patients either had their usual care or they were given this 8-page brochure, which was in large font and talked about alternatives to sedative hypnotic drugs for sleep. And what happened? 6 months later, just by being given this brochure, 27% had stopped their benzodiazepine compared to only 5% in the usual care group. And another 11% had a dose reduction. So that's a pretty powerful effect for just giving people information. So coming back to the steps for addressing polypharmacy. So the first step is actually to have an accurate medication list. So that means confirming all the medications, including over-the-counter vitamins, supplements, herbals, and then also importantly asking about alcohol or other substance use because alcohol will also interact with medications. And really the first step is there an indication for each medication. So I included some of the details of our case. So you can see maybe the gabapentin is for his neuropathy. There are some antihypertensives and he's on a statin, metformin for diabetes, maybe the zolpidem for his insomnia. He's got medicines for his prostate. So by and large, I would say there's an indication for each medication. Now, is the dose appropriate? And I know for simplicity, I didn't put all the doses here, but because of his renal insufficiency, I would want to know what his doses of his gabapentin. The metformin is probably okay, but I would keep that in mind as well. And then also assessing if he came in with a symptom or you've been dealing with a symptom, could it be a side effect of a medication? And specifically, this is because we want to avoid the prescribing cascade. So what is this cascade? So for example, someone is taking an NSAID, and I forgot to point out on the last slide, actually, he was taking, in addition to the medications he knew about, PRN, naproxen, and 4 other vitamins. So someone's taking an NSAID, his blood pressure goes up, gets started on a medication, amlodipine. That then causes ankle swelling. So someone gets started on furosemide. Then you get low potassium. So you get started on potassium supplement. That makes your stomach upset and you feel nauseated and you get an antiemetic. And while this seems kind of like an extreme, it is very common. And you can see how rapidly, if you don't stop at some point, that cascade can continue. So those are the first 3 steps: dose, indication, and are there a side effect? And the next is to look for drug-drug interactions. So in this case, I would want to know what the dose of metformin is, because you wouldn't want to probably go above 1,000 milligrams because of the dolutegravir. Confirming what those vitamins are, is it calcium or iron? Because then you need to also look at the timing with the dolutegravir. Are there any potentially inappropriate medications? In this case, taking zolpidem, and that is on both the Beers and the Start-Stop list. And then are there other concerns? This might be co-payments. This might be struggling with adherence. Some medications might be 3 times a day. One's supposed to be on an empty stomach. One's supposed to be at night. Is it just getting too difficult to manage? And in this case, we know he is talking about wanting to reduce the number of pills, or he's struggling with the number of pills. So this is a good time to talk about this. And maybe it means it would be stopping the naproxen because of his renal insufficiency. It might be looking at what vitamins, or maybe it's addressing the zolpidem. So again, it's really talking through with the patient about their preferences while also addressing your concerns. Just to point out, for drug-drug interactions, if you're not aware of the HIV Liverpool website, hivdruginteractions.org, you can quickly put in someone's antiretroviral regimen and their calcium supplements or other medications, and it'll pull up whether there's an interaction or not. I just note, of course, ritonavir and cobicistat having significant drug interactions with a lot of medications, including even inhaled and intranasal corticosteroids. And that, like with dolutegravir in this case, also you need to know vitamins, supplements, other over-the-counter medications someone is taking. Another resource I just wanted to share, this is a new network in the US, only 1 or 2 years old, to really hone in on deprescribing research. There are resources here for both researchers as well as links for clinicians, including deprescribing.org, which is where those brochures that I showed from the Empower trial are housed that you can download and share with your patients. So again, we're seeing a lot of patients with multi-complexity in HIV, and talked about multimorbidity and some of the approaches, and then how we can approach polypharmacy with those 6 steps and thinking through potentially inappropriate medications and drug-drug interactions. So I want to switch to talk about geriatric syndromes. And today we're going to focus on frailty, falls, and functional status. So first, what is a geriatric syndrome? So traditionally, we think of syndromes like Cushing's syndrome, for example. It's usually one process, cortisol excess in this case, maybe because they're taking ritonavir and an inhaled corticosteroid. And then it leads to all these different signs and symptoms or phenomenon. So truncal obesity, skin thinning, and osteoporosis. The geriatric syndrome is the reverse. So it is actually multiple processes that contribute to one specific syndrome, in this case, delirium. So someone has some underlying cognitive impairment, they get dehydrated, they also have hearing loss, they're started on a new medication. All of these things then contribute in turn to delirium, and you really need to address all of these things to resolve the syndrome. So additionally, this was a conceptual model around geriatric syndromes. Many syndromes actually travel together and share risk factors. So things like increasing age, cognitive impairment, all can contribute to geriatric syndromes like urinary incontinence, falls, delirium. In this case, in this model, they pull out frailty as kind of the, like the meta syndrome, but you can see the directions of these arrows that all these things are actually interconnected and can occur at the same time. But really why we care about geriatric syndromes is they lead to outcomes like dependence in ADLs, IADLs, which often in turn leads to long-term care placements and death. So what do we know about geriatric syndromes in people with HIV? So this is a study now that's several years old that we did in San Francisco in the SCOPE cohort, looking at geriatric syndromes. And you can see that across the board, many of these syndromes and conditions were common. You can see falls occurred in 25%, having an abnormal cognitive screen occurred in almost 50%, having difficulties with instrumental activities of daily living like managing medications in almost half, and pre-frailty seen in just over half of the population. And in this group, the average age was 57. Everyone hadn't had an undetectable viral load for at least 3 years. And a lower CD4 nadir, increasing comorbidities were associated with having more geriatric syndromes. Interestingly, we saw that people who had been on earlier drugs like AZT and DDI had a lower incidence of syndromes, some of that which might be a survivor effect, though was not what we had hypothesized. But just to point out that geriatric syndromes also travel together in people with HIV. This is one example showing how frailty and falls are associated with each other. In this case, this is from this 2017 study. People who were frail compared to non-frail had a much higher odds of having recurrent falls. Similarly, although less effect with pre-frail was seen. And I included some other references here, again, showing associations with frails and falls, as well as cognitive impairment and other geriatric syndromes. So I want to talk first about frailty, because I think this is probably the most discussed geriatric syndrome. And I highlighted this article here from my colleague, Dr. Falutz in Montreal, who's a geriatrician working with HIV, because really, is thy name universal? Because there are so many different frailty scales out there, and it can feel very daunting. Well, which one do I use? But ultimately, there's kind of two big boxes for frailty assessment, and that is the Fried Frailty Phenotype, which is this physical phenotype of frailty, or the Frailty Index, sometimes known as the Cumulative Deficit Model. So I'm going to focus on those two, both of which have been studied in people with HIV, but I included some of these others because these we'll talk about. Some of these are actually probably easier to implement in busy clinical practice than the two that have been most studied in research. So what is the Fried Frailty Phenotype? This is by far and away the frailty measure that has been most used in HIV. You can see there are 5 components: shrinking, exhaustion, weakness, slowness, and low physical activity. If you meet 3 of the 5 criteria, which are measured by these assessments, you are considered frail. And if you meet 1 or 2 of the criteria, you are considered pre-frail. You can see it's a combination of objective and self-report measures. And this phenotype has now been examined in many of the large US cohorts, as well as some European cohorts. And in general, seems to show that there's an earlier occurrence of frailty in HIV. That was in the MAX study. And in many, there's an increased risk of frailty or increased prevalence of frailty amongst people with HIV compared to the HIV negative group, but not across the board. And especially in some of the recent work since 2019 in the WISE, it was the HIV negative group of women who had a higher prevalence of frailty than the HIV positive group. And what was shown in some of the earlier studies in the WISE and in the VAX and also in the ALIVE cohort is that it was really the increased prevalence of frailty was driven by people who had lower CD4 counts or viremia, maybe not surprisingly. And that frailty is associated with inflammatory markers. Some of the studies have looked at like IL-6 and TNF-alpha. There have been studies looking at visceral adiposity and other measures of body mass, and those have been associated with frailty. And importantly, just as in the general population, it's now been shown to be associated with incident hospitalization as well as mortality. So predicting those same outcomes that we care about in the general population. The frailty index, so those 2 big buckets, one is Fried, one is the frailty index. And it's called sometimes the cumulative deficit model because it's looking at this cumulative burden of health deficits. So it's not a unique phenotype of physical things, physical measurements. It's this cumulative burden and can include things like comorbidity, certain lab markers, cognition. And the original frailty index included 70 components. They did various validation studies and found to get the best prediction, you usually needed at least 30 components in the model. And essentially for each item, you have yes, 0, or excuse me, yes, 1, 0, no, and you end up with an index summary score of all those things between 0 and 1, with usually a cutoff of 0.25 as being considered frail. In terms of people with HIV, the group that I've seen that's done the most work with the frailty index is Dr. Giraldi's group in Modena, Italy. And you can see here, this was one of their studies where even after adjusting for other traditional risk factors for mortality, the frailty index did predict mortality after adjusting for age, CD4 count, and also injection drug use. I mentioned, there are all these different tools, and not to be overwhelming, but I think all of these tools are essentially trying to capture vulnerability to disease, vulnerability to death and nursing home placement and those other outcomes. And so I think the FREED and the Frailty Index are important research tools, and certainly they are prognostic tools because they are associated with mortality. So important for thinking about someone's prognosis and making treatment decisions with a person in front of you. But I will say some of these can be challenging to implement clinically. Can you really pull 70 things from your EMR? Maybe. Can you do all 5 of those freed components? And really they were based on the lowest quintiles of a group. So you have to be able to compare to other people. But it might be that you can do something like gait speed alone or grip strength. The VAX index, which is shown here, has also been proposed as a frailty tool, has been associated with fragility fractures, hospitalization. It is a prognostic index. It does have fewer variables than, say, the frailty index itself. And this is the older version. This is not VAX 2.0. So maybe it's VAX plus something else. And I highlighted some of on the other slide, like the Edmonton Frail Scale has been heavily used in geriatric oncology. It's actually in one of my hospital systems medical record because the oncologist built it in. So there may be other tools. I've only seen one study of that particular assessment though in people with HIV. So just to point out, frailty and disability, they are distinct concepts usually, but they overlap. So again, all of these things travel together. This is from one of Freed's studies. In this case, disability meaning dependency and activities of daily living, excuse me. And when you hear geriatricians talk about functional status, this is what they're really talking about, is this self-report of functional limitations and disability. So ADLs, which as many of you are aware, are basic tasks like bathing, dressing, toileting. IADLs, which are things like managing medications, getting to appointments, doing, your finances. And if someone is having difficulty with really 2 or more of these things on the left, they probably are needing 24-hour assistance. Whereas on the right, you might be able to get someone in-home support services or other intermittent services to help address these needs. There are assessments that can look at functional limitations. I'm highlighting this one, the short physical performance battery, because it's been used in a lot of studies of people with HIV, as well as has been shown to predict mortality. It's essentially a measure of lower extremity function, includes balance tests, a gait speed, and a chair stand test. And this is in data from the ALIVE cohort. We're here where the group had an average age of 51, having abnormal short physical performance battery score. In HIV, the group who was HIV positive and had abnormal scores had the highest risk of 5-year mortality. So again, this is a tool that was originally designed for people in their 70s and 80s, but still had predictive validity for younger people living with HIV and at risk for HIV. So other practical things to look at functional limitations and disability. So there are other assessments you could do, the timed up and go, which is getting out of a chair and timing someone on a 4-meter walk, chair stands, gait speed, functional reach test, which gets at upper extremity. And just to point out that how you ask about disability matters. So if you are working in an outpatient setting, you need to ask about difficulty first, because the majority of your patients, unless they are coming from a nursing home or other long-term care facility, probably don't have multiple deficits in ADLs. So asking about difficulty gets at those functional limitations earlier, where you can hopefully intervene before someone is really dependent and needs help. So asking as a two-part question. And I think it's also really important to normalize that this is something I do for everyone, because our society is so focused on independence and ableism that this can also be a stigmatizing thing to ask patients. So coming back to our case, this is a 68-year-old. We talked about his multimorbidity and polypharmacy, and maybe are addressing the polypharmacy. So let's say you do a frailty assessment. In this case, you decide to do Freed and he's pre-frail. For function, you ask about his ADLs. He's independent with all of them, but he already mentioned having difficulty managing his medications. He also mentions he's having some trouble bending down to do certain cleaning tasks. For being thorough here, I put down his MoCA score, which was 28 out of 30. And so he didn't have any cognitive symptoms. So you decide you're going to do fall risk screening. So you ask 3 questions. Have you fallen in the past year? Do you feel unsteady when you're standing or walking? And he says yes. And do you worry about falling? So now we've talked about frailty, we've talked about disability, and now I'm going to talk about falls and why falls. So this is again data from the CDC, which has taken on falls as a public health problem. Because again, in 2018, 1 in 4 older adults had a fall, or roughly 36 million falls in that year. And more than 30,000 people died from a fall. And here they say that it works out to be about 88 older adults a day dying as a complication of a fall. In people with HIV, we know there's an increased risk of fracture, increased risk of osteopenia and osteoporosis. So I think it is absolutely critical that we start addressing fall risk for our older patients. What do we know about falls in people living with HIV? This table was put together by my colleague, Dr. Erlinson in Colorado. And really across all the studies, so max-wise, again, large cohort studies have looked at falls. And it actually looks like overall, the rates of falls are similar between HIV positive and HIV negative. It's not that there's necessarily increased frequency of falls. But in people with HIV, alcohol and substance use, medications and polypharmacy, peripheral neuropathy, probably mediating balance problems, cognitive impairment, and frailty were all associated with falls. So again, these syndromes are traveling together. And you can see across the board in all these different studies, ranges between 18 to 40% for having 1 or more falls. And again, in relatively younger ages, these are people younger than 65 on average. So I highlight the CDC screening. There are other algorithms. Their screening is actually based on the American Geriatrics and British Geriatric Society recommendations. And because on their website, they have all of the information I'm sharing. There are pocket cards you can download. There are videos on how to do assessments. So our patient actually screened at risk for falls. So if you answer yes to one of those 3 questions, and this comes to our post-test number 2. So if you answer yes to feeling worried about falls, feeling unsteady, or having a fall, you should automatically go to a full fall assessment. Talking about fall prevention is important for anyone, but if someone answers yes to one of those questions, you really need to dig in a little bit more. And again, this is all on the website. But one of the next things you would do is evaluate someone's gait and their balance. And again, you could use those assessments of functional limitations, timed up and go, the short physical performance battery, which includes balance tests. You're going to look at medications. So again, looking at those inappropriate medications is appropriate for falls as well. Looking at orthostatic blood pressure, looking at someone's environment, or at least asking them about the environment, checking someone's vision, looking at their feet. So again, these are multifactorial conditions, so you need to do assessment of multiple domains. And then you're going to develop your treatment plan according to what you find. So coming back to our case, so he says he feels unsteady. So you ask him more what that means. Turns out he feels dizzy when he gets up out of chairs. And if you look at his meds, he's on multiple antihypertensives. He's also on an alpha blocker for his BPH, and he's also taking zolpidem. He also reports that he's been having some decrease in his visual acuity, denied having home hazards like tripping hazards or poor lighting. You also notice that he hasn't had a DEXA to assess if he has osteopenia or osteoporosis. And then on his exam, you check orthostatics, and he actually is orthostatic. The systolic blood pressure drops by 20 points. He has this history of neuropathy, and he actually has decreased sensation in his feet, but you notice that he's wearing sturdy shoes. And you do part of the SPPB and notice that he does have difficulty with his tandem stand, suggesting he has some balance difficulties. So what could you do here taking in that information? So he was orthostatic when we saw him in clinic. So it was a little more urgent, and we went ahead and stopped his amlodipine, which had been recently started, and gave him a blood pressure cuff so he could monitor his blood pressure at home. We also talked about him taking his tamsulosin at night. And just to point out, probably tamsulosin is probably the best choice here of his alpha blockers. Often I see people who are on terazosin plus multiple blood pressure agents. So that can absolutely contribute to dizziness and orthostasis. Already have talked to him about alternatives for sleeping as opposed to zolpidem, which can contribute to falls. He had evidence of balance abnormalities, so you could refer him to physical therapy, or you could give him some home exercises, and the National Institute on Aging has videos and things you can share with patients on how to do these exercises. And then he also had trouble with his eyesight, so you can refer him to ophthalmology. So what happened in this case? So putting it all back together, actually you stopped his naproxen because you were concerned about his renal insufficiency and also thought it might be exacerbating his blood pressure. Because of the orthostasis, you stopped the amlodipine. He monitored his blood pressure, and actually it turned out he did not need the amlodipine to be restarted. He is considering a zolpidem taper, and that's what you're next working on. And again, sometimes people can feel very attached to a medication or worried about stopping it, especially if they've been taking it for many years and are tolerating it. And so I really think about addressing PIMS as also really motivational interviewing and trying to understand what someone's views are, and then talking about some of the risks and benefits of those particular medications. He also had difficulty with some of his IADLs. So you were able to get in-home support services to come once a week and help with cleaning his apartment. You were able to get him adherence packaging after you made these changes to his medications to help with his adherence from his pharmacy. His dizziness stopped after you adjusted the blood pressure medications and you ensured he was taking the tamsulosin at night. He went to ophthalmology and he got new eyeglasses, and he also went and had a DEXA scan that turned up normal. So what are some of the take homes here in terms of assessing geriatric syndromes? I think the first point actually is you have to ask, because older adults may not volunteer this information, especially things like incontinence, or, there is stigma around many of these things, including memory, having difficulty with daily tasks. So if you don't normalize and ask, it may not come up. And also times people often assume that these are normal parts of getting older. I think it is a weekly conversation that having incontinence is not a normal part of getting older, and we might be able to do something about it, or that falls are not a normal part of getting older. Really, what all of these things, especially frailty and other syndromes, are trying to capture is this vulnerability to poor outcomes. And we talked about, for frailty, some of the tools used in research and clinical practice may differ. And ultimately, hopefully, we can find ways to better align them. And then really these frailty assessments, the assessments of functional status, also help give a sense of someone's overall health and prognosis, which comes back to coming up with those individualized treatment plans for someone with multimorbidity. And also, the syndromes have shared risk factors. So things like addressing polypharmacy and working on someone around exercise or other non-pharmacologic interventions can address multiple concerns. And I think just to point out that this is even more important since COVID-19. And I just want to talk about how we can adapt assessments for telehealth and what I've been seeing in the last year. So we know that older adults are at increased risk for complications or severe illness from COVID-19. What we have also been seeing are some of the consequences that go along with shelter in place orders. And that is really increased isolation, increase in mental health concerns and substance use. And this is not just in older adults, but just to point out what I have been seeing clinically. I've seen some people who have been so afraid to leave their home that they actually have not been active at all. And I saw one person who now is struggling to get out of a chair, for example, like this decline in function and activity. Other people have had challenges keeping their caregivers. And I've seen a lot of cognitive decline and physical function decline, increased fall risk. So just to acknowledge and to say that these things are even more important now. So how can you adapt some of these assessments? Because I think telehealth is here to stay, even in a post-COVID world. So first, if you're in a clinic that doesn't have video capability, but only has phone capability, you can still ask those 3 false screening questions. You can ask self-report of function. There are things you can still assess on the phone. If you have video capability, you can watch someone walk. And if they're not too unsteady and you're worried that they might fall during your assessment, if they don't have someone at home to help them, you can see somebody get out of a chair or do a balance test, things like that. I will say there are some advantages to the video visit. So one, you can see someone's home environment, which gives you critical information, especially for fall risk. Med review, you might be trying to get someone to bring all of their medications into clinic and it's never happened. Now you can say, please go into the kitchen and bring out all your pill bottles and look at them. And I have done this frequently in the past year. And then also patients have shared that it actually improves their access. So some patients who have limited mobility, where it can actually, by the time they get dressed, get in, get to the clinic, it can actually take them more than an hour or a couple of hours to prepare to come in for that 20-minute office visit. And so can actually improve access for people who have limited mobility. And I did want to share an additional resource, and I'm going to talk more about resources where you can learn more about geriatric assessment. But this is from our Northern California Geriatrics Workforce Enhancement Project. You can get CME hours as well. That talks about how to adapt some geriatric assessments to telehealth. But often, I'm sure at this point, you're like, this is great, but how am I going to do this? I completely understand. And I understand that it feels overwhelming. I can barely get through the things I need to do in 20 minutes. How can I add on? So I think, first of all, there are a few programs across the country, including where I work at San Francisco General, focused on HIV and aging. But ultimately, it's going to come down to what are your local resources and how you can adapt maybe what other programs have done to your local resources. If you're in an area where there are not geriatrics or you can't have a geriatrician in clinic like what I do, are there telehealth options that you could use, for example, even if it means the patient comes into the clinic because they have trouble navigating telehealth and then you reach out to the specialist together. You are probably already addressing one of those 5 M's. Maybe it's medication, maybe it's mobility, or maybe mental health. You can pick one to start and just go with that. Asking the 3 CDC STEADI questions, for example, takes less than 1 minute to incorporate that in a workflow. And then like, who else do you have to help? Yes, this is a lot for one provider to take on, which is why the the comprehensive geriatric assessment is based on a team-based approach, but depending on your practice setting, you may not have those resources. So how can you do this? So if you do have the staffing, I would say encourage having other staff do the assessments, and then the provider can work on screening and treatment plans. A lot of geriatric models of care are nursing led. And so just to point out, we should be using our nurses and other team members more. Pharmacists in role of addressing polypharmacy, for example. So you can use that team approach. If you don't have all of those resources, you can also break this into serial visits where maybe at your routine visits, you're going to address one thing. And that might mean in the era of telehealth that you might not have the patient come back physically every time, but you might be able to have them add on a phone visit or a video visit to address some of these concerns. And that ultimately, though, by assessing some of these things, you are getting a better sense of someone's prognosis and how they're doing in their day-to-day, which then helps you to guide those treatment decisions. So where can you learn more? So of course, there are other resources. There have been other webinars on older adults, as well as online cases through IAS. The AETCs through the Ryan White and HRSA program. All I know for sure the Pacific and the Northeast Caribbean have topics focused on HIV in older adults. And then a resource you may be less familiar with, which is the HRSA Bureau of Health Workforce, so separate from the HIV/AIDS Bureau, many of us are more familiar with, includes these geriatric workforce enhancement programs, which I shared. So there are 48 of these programs around the country. We know that Northern California, Chicago, and New York are all doing programs in conjunction with Ryan White clinics. So there is some precedent for this. And so this is something you could look to see if there is a program in your area and reach out to them around partnering for training for your staff or your training for yourself, because that is the focus of these programs. So in summary, I know we've talked about a lot of different things, but the highlights, we talked about multimorbidity and polypharmacy, and really this multi-complexity is very common in older people living with HIV, and it requires a unique approach. Talked about resources for multimorbidity and thinking about prognosis, and we talked about a 6-step approach to polypharmacy, where, and this will come back to our post-test questions, reducing potentially inappropriate meds is often a really good place to start. And simple interventions like giving that brochure can have big effects on reducing those medications. Talked about geriatric syndromes, which are multifactorial, and we know that they predict mortality and really are identifying who is at risk for poor outcomes. We talked about frailty, with the Fried frailty phenotype being the most commonly used in HIV. And then we talked about functional status and disability, and that you can ask about ADLs and IADLs, or you can do more objective measures of functional limitations like the SPPB. And then we talked about falls screening and the CDC STEADI algorithm, those 3 screening questions, and all of the resources available on the website. And finally, we talked very briefly about how a lot of these assessments can be adapted to telehealth. So with that, I'm going to now go to our post-test question. So again, this is a 63-year-old cisgender male who has HIV, hypertension, COPD, diabetes, arthritis, chronic kidney disease, who's struggling to take his meds. He's taking 7 plus his antiretroviral. So which of the following is the best initial step to address his polypharmacy? Is it switching his ART regimen? We know dolutegravir maybe has fewer interactions, although not 0. Is it identifying potentially inappropriate medications? Is it counseling on ART adherence, or nothing you can do? He has so many comorbidities. And we've gone to 99% getting the correct answer of identifying potentially inappropriate medications. So The Beers criteria, stop start, which you can download from the internet and use as a guide, or those tables in the European guidelines as a guide of places to start. And our next question, so a 75-year-old cisgender female who has HIV, hypertension, diabetes, peripheral neuropathy. You decide after hearing this talk that you're going to do those 3 CDC STEADI questions. So she answers by saying she has not had a fall, she does not feel unsteady, but she does say she is worried about falling. So she has now screened for one of the 3. What is the next best step? Is it nothing else is needed? You can reassess in 1 year. Is it to evaluate her gait as part of a falls assessment? Or is it enough just to provide education on fall prevention? Great, and also we increased here. So correct answer is evaluating her gait because she did have a positive screen. Providing education on fall prevention is also important. And I'd say it's not a wrong answer, but the better answer would be you need to go into more assessment. Why is she worried about falling? Is she having trouble with balance or other things? And so the evaluating her gait is the next best response. And with that, we're going to go to our Q&A. And I know there were questions submitted in advance. Hopefully I was able to answer some of them. And then I'm going to look at the questions that have come in the Q&A box as well. So I see a question from Nick. Are there any ART regimens that stick out as significantly better or worse than the other preferred regimens to target viral reservoir in the CNS? Mild HIV-related encephalopathy is a perplexing problem for me. Yes, agree. It can be a perplexing problem. So I'm thinking of like the CNS penetration scores, which I'd say is still really controversial unless someone has a case of CSF escape, where then it is warranted to adjust someone's antiretroviral regimen based on the testing in the CSF. Most of the integrase inhibitors do have high CNS penetration. And specifically, I don't know if they're necessarily addressing the viral reservoir, but I think in theory, if they had higher CNS penetration, that would get at that. There's a question, is the period of disability with aging increased or decreased in older HIV patients? Is the lifespan equal to that of persons without HIV, or is it shorter? So great question. And the 2 parts, the first part, period of disability with aging increased or decreased. I don't know. I think I've seen one study looking specifically. So this is that concept of compression of disability in older ages, which is the goal of some of the senolytic studies where I think we have to be really cautious about saying curing aging, but is it curing aging, extending lifespan, or is it actually trying to decrease the disability period at end of life? And I am not off the top of my head, I think I've maybe seen one, but I don't know that we have a lot of data to say whether it's increased or decreased in people with HIV. There are studies around life expectancy in general. And in general, we know that while people living with HIV are approaching a near normal lifespan of someone that does not have HIV, lifespan is overall shorter. There's a question about which frailty assessment would you recommend for routine care for older people living with HIV? by non-geriatricians? Is it the Frail scale? And also the MoCA. So I'm going to take a quick minute just to talk about, because I know there were a lot of questions in advance around cognition and tools. I do think in terms of what you can do in a clinic, probably the MoCA is the best test that we have of the short screening tools. It has been validated for hand HIV neurocognitive disorder, and has better sensitivity and specificity, although it's still not great. It's around 60, upper 60, 70%, but is better than the MMSE or even the HIV dementia scale, which is really only good at detecting severe dementia, not the milder forms we see now. The mini cog, if you really needed to do something quick and dirty, takes 3 minutes and probably does get at executive function, but it may not really capture everything. And then I will say I've seen one study using one of the shorter tools, the Edmonton Frail Scale in people with HIV, in a study that came out from Australia. So I think we need more. In that study, it did have some overlap with both the frailty index and the Fried frailty phenotype, but I think we need more. I see a comment from my lovely colleagues in Canada, Dr. McMillan, using the clinical frailty scale in Canada. And I know there's been a lot of work around the frailty scale during COVID as a way of understanding people's risks of COVID, because it is partially driven by frailty and not just age alone. Jacqueline, I don't know that I would love to see your data. I think it is another example of a short tool that may be better suited for busy clinical practices. And I think the main thing with frailty, some of the criticism of Fried's model is that it doesn't include cognition or social domains like the cumulative deficit model. It's a physical model of frailty. So I think if some of these shorter tools also capture those domains, then that could be useful. There's a question from Dorcas Baker. Hi, Dorcas. Now that we see people with HIV showing earlier geriatric issues, what can be done to diminish frailty at earlier ages and what age? And I do think it's important to say, I don't know that we have the data on what age is best to screen. I do think it's worth considering trying to start screening people at 50, since that's what we're using as the common definition of aging in HIV. And I think one of the biggest things, so I specifically talked about reducing harmful medications and exercise for a reason. I think exercise can help with so many things, including frailty, functional limitations, and cognition. I know there are some small studies looking at exercise in terms of hand. We need more data, but I think exercise does not hurt people, and potentially helps with addressing frailty. Question about sexual function in older adults with HIV. In general, such stigma around sexuality in older adults, plus this population, even with the clear data around U equals U from Dr. Goldstein at Mount Sinai. Yes. So I think first we just need to acknowledge the ageism that exists also in the healthcare system, and that includes talking about sexual health with older people. There are very few HIV prevention campaigns targeting older adults. The one I often think of was one done in New York City several years ago. And I agree, Nathan, that this is something that should be talked about. We know just in general across all people, not just in HIV, that older adults infrequently are asked about sexual health concerns over the age of 50. So I think it's something to think about, even as part of geriatric assessment. If you want to holistically address someone's health, you need to also talk about their sexual health. And then there's a question about from Dr. Burton about recommendations on ways to help encourage older, possibly technophobic patients to become more comfortable with devices. Great question. I think one, again, I think I see a range. Some of my oldest patients in their 80s actually are doing all their appointments on video over Zoom. So what I have seen though, is that for a lot of patients, it's actually the digital divide, meaning that here in San Francisco, so close to Silicon Valley, patients who don't have internet access, who can't afford a device like a smartphone or a laptop or a tablet to be able to access these things. And so I think we also need to think through resources to really address that digital divide for our patients. And some of it is it takes more time. I know a lot of groups have focused on phone outreach to people to help them try to get online, help them navigate Zoom or help them navigate devices. And we've seen firsthand it actually has involved sometimes patients having to come in and meet with someone in person and to sometimes do that more than once to get the training on the device. So I think we need to think about providing training to continue with telehealth. And then there's a question from Jules. Hi, Jules. One concern is that our HIV healthcare system and the Ryan White care system is not able to expand due to time limitations and medical visit to include these types of geriatric care. What do you suggest? And Jules, I know we've talked about this before. I think, I think there's a lot of reform that needs to happen in the healthcare system. And if we actually tried to structure our care to best serve those with the most complicated needs, I think we would all be better served. I tried to come up with some practical strategies. So it might be that you can't do everything at once in one visit. It's just not possible. Or it might be that you take one annual visit, whether it's maybe using some of the things in place from Medicare, like the Medicare annual wellness visit, which allows for cognitive screening and functional screening and does not include a copay, for example. There may be structures like that. And I will say also that I feel like this in 2020, despite all of the limitations with COVID, I feel like there have been more discussions with HRSA, and that include the two HRSA bureaus, both the HIV/AIDS Bureau and that Workforce Enhancement Bureau, thinking through how we can train people, because not everyone's going to have access to geriatricians. And you're right, Jules, that there are system constraints. And for now, I think we have to just come up with short assessments and practical solutions to try to address things over time, or taking one visit where you're going to hone in on issues. We have just a few minutes left, and I wanted to be sure to try to address some of the questions that came in advance. Hopefully we did talk about some example screenings. That was one of the questions. I briefly touched on minimum screenings and recommendations, and actually the IAS guidelines are suggesting, annual, and then depending on the result of a frailty screening, either continuing annual or spacing out. I think that's reasonable. I think, again, we don't have clear data to support that, but I will also say we don't necessarily have clear data on supporting the frequency just in the general population. And I think, these are things that are important to people's quality of life. And I think it does make sense to assess for these conditions. And I would say at least doing one annual assessment to see where someone is, and then adjusting frequency after that makes sense. Noting that some people might even need more frequent touches, not necessarily assessment, but to develop that plan, because assessment is not just assessment, but also developing a treatment plan. And then I know we didn't have a lot of time to talk about specific care models. And just to say, if you do have specific questions, you can also email me. It's my first and last name at ucsf.edu. And I know there was a question about if you don't have geriatrics, gerontologists in your community, would it be prudent to have practicing IDs get some credits? And that's why I mentioned some of those resources at the end. Look to your AIDS Education Training Center, see if there's a geriatric workforce program in your area. you came to this talk today. I think it is absolutely critical because I think most of our patients prefer to get their care in their HIV clinic. It's where they feel safe and not stigmatized. So I think some of it is, if you can't have a geriatrician embedded in your clinic, how can we increase the knowledge of staff and everyone else? And then there will be other sessions coming up on neurocognition and mental health, which I wish we had time to talk about today. But stay tuned. And in our final minute, I'll just say thank you to everyone who attended. Please, if you have questions, please feel free to reach out to me. And it's very clear that we need a whole session on neurocognition. Thank you.
Thank you, Dr. Greene. As a reminder, evaluations and information on how to claim continuing education credits will be emailed by tomorrow at 5 p.m. Pacific time, and this will enable us to review all of those that have attended today's live broadcast. To view upcoming webinars available for sign up, please visit the IAS-USA website. The next webinar is in 2 weeks, and that will be an update on investigational new drugs with Dr. Iran. Additionally, a list of upcoming IAS-USA courses is also available on the website. And the next one coming up will be an update from CROI, which is a 2-part series. Additionally, if you are interested in learning more about aging and HIV, we have a newly added virtual course that will be held on June 25th. Here's a list of topics that this course aims to cover, and additional information is available on the website. If you haven't accessed the virtual CROI 2021 abstract ebook, it is now available for public access, and you may visit the croiconference.org website to view. And here is a list of an upcoming dialogue and recent on-demand dialogues, which is available on the IAS-USA website. For additional updates, make sure to check our website. Lastly, we'd like to thank our presenter, Dr. Greene, the audience for your participation, and to all clinicians working 24/7 to continue to provide care to patients with HIV. Thank you, and this concludes today's webinar.